Good morning, everyone, and welcome to Sierr Update 2025. My name is Valerio Pisaturo. I'm the president of the Italian Society of Embryology, Reproduction and Research, Sierr. For the first time in our history, this event has been held in collaboration with ASEBIR, PECE, SPMR. 4 different countries, Italy, Spain, Greece, and Portugal, connected by multiple professional collaboration. And this gave us the idea to organize this event. Before to start, I would like to thank, obviously, our sponsor. Without their support, this event would never be happen. So thank you so much for this. And now I will hand over to the other representative for the brief greetings. Thank you.
Thank you. I would like to thank Sierr for this initiative, especially Valerio, Giovanna, Stefano, and Christian for allowing us for being here with you. It's a pleasure. We are very alike, Portugal and Italy and Greece and Spain. And I hope this will be the first of many events. So thank you very much.
Thank you, Valerio. On behalf of the board of the Greek Association of Clinical Embryologists, I would like to thank Valerio and all the organizers of this gathering. I believe that this is a very important initiative, and I wish to continue with this very special getting together and create very good things in the future. Thank you.
So I'm going to say the same things again. Thank you very much for organizing this. It's a pleasure here to be with colleagues from the Mediterranean region, and I hope that this initiative continues and we can make more meetings in different countries and just expand this collaboration between these societies. Thank you very much.
Thank you. And we truly hope that this is only the beginning. That's why it's a great pleasure for me to introduce our Vice President, Professor Luisa Campagnolo, who will share with us our next project. Thank you so much, Luisa.
So good morning to everybody. It's a real pleasure for me to present an idea that with Valerio we were thinking about over the last 6-8 months, which is, if I can put the slides. So the idea is to take the occasion of this meeting with the 3 other European societies of having or try to have a cost action on potentially the subject of the today meeting. So for those of you who are not familiar with the cost actions, these are pan-European initiatives, which means that they include 41 countries from Europe. They are open to any initiative, which means that we can think about a common project, and I will show you in the last slide the idea we put together. I don't know how does it work to go on? Oh, okay, sorry. So this is actually a 4-year project, and as you can see, in the project there could be universities, research institutions, small and medium enterprises, and also companies of the private sector. So it's really open to everybody, and there's funding for each project that should be around 500,000 euros. What is it funded with the cost action? You can see here. So there are no money for research, but we can pay meetings, which means that the group participating to the cost action, they can get together and they can take the occasion to discuss common initiatives, ideas, projects. There is the possibility to have, especially the young researchers, to move around the different countries through these short-term scientific missions. There is the possibility to organize training schools. And again, there's a huge idea of supporting the young people to get into the field. And then also the possibility to sponsor young researchers below 40 years of age to attend to meetings that are not organized by the partners of the cost action. The organization is very simple. It's like the regular organization of the EU project. There is a management committee which coordinates several working groups that are dedicated to the different initiatives of the project. Plus, you know, there could be also other people involved if needed. This is the map of the countries that can be involved in a cost action. In the green color, you see the ones that actually need to be included. They are mandatory. So there should be at least 7 different groups, 50% of which should be of one of these countries in green. I don't want to take more time because we need to stay on the schedule. These are the ideas that we came out with. We can discuss this. The reason we wanted to talk about this initiative now is to give you enough time all over the day to think about it and to come up to me or Valerio or Giovanna or Stefano and say if you are interested and if you think that these potential subjects could be further discussed. You know, for example, standardization and harmonization at the EU level, the idea of, again, sharing technological innovations, personalization of fertility treatments, and I mean, I don't want to, again, take more time, but just to give you an idea, the point 7, the big data in European art registries. This is something that I know have been tried already and didn't really work, but I think that with enough effort, maybe we can have it working. So this is it from my side, and I again would like to invite you to consider this initiative and contact us to discuss further. Okay, that's it. So I want to call on stage now Giovanna De Medio and Stefano Canosa, which actually put a lot of effort in organizing the today meeting.
Good morning to everyone. My name is Stefano Canosa. I just would like to spend a few words about the scientific rationale about this event. As for the Sierr Update 2025, we will explore the case stages of the in vitro fertilization treatment with the aim of sharing the most recent advancements and the ongoing challenges in the field. Particular attention will be given to the details of the laboratory practice for a continuous improvement and optimization of the success rates of our patients. So based on this, the scientific program of the event will be divided into 4 main sessions, each one held by a different scientific society and addressing different topics of the IVF, going from gamete selection through insemination, embryo culture, cryopreservation, embryo biopsy, and PGT.
Hi, I'm Giovanna De Medio, And as you know, at the end of, if you have seen the program, there is a survey. We prepared a survey together with all the directors, the scientific committees from other scientific societies. And we invited you, mostly the director of each IVF laboratory, to answer according to the use, so that at the end of each talk we can discuss differences among different laboratories and across different countries invited here. And hopefully we can take a home message that how to improve or harmonization of everyone. And that is it. So I invite the first speakers here on stage. Thank you.
Everyone, welcome to this first session of the morning. It's in charge of ASEBIR. I'm Irene Cuevas. I am part of the ASEBIR Scientific Society, and together with Alessio, we'll do the moderation of this session. So our session will be surrounding both gametes, the male gamete and the female gamete. So we will talk about the sperms and oocytes and how to select, how to culture them, how to freeze them, everything. So my first speaker is Dr. José Luis Girela. He works, he's a professor of the University of Alicante in Spain, and he is currently the president of the Special Interest Group of Andrology inside the society, inside ASEBIR. So the floor is yours. Welcome.
Thank you very much, Irene. Well, the first thing that I want to say is thanks to the organizing committee for inviting me to give this talk. It's a real pleasure for me to be here in Naples with a lot of colleagues, friends, and also some students. I will talk about the sperm selection techniques, and I will try to focus on the current situation and how we can improve the results by improving the selection that we can do. This is the outline of the talk. I will start talking about what happens in natural conception to go through the classical sperm selection techniques, moving to what we call advanced or new selection techniques, and to end up with a personal opinion that microfluidics will transform the sperm selection techniques that we have. You all know that in natural conception, after the ejaculation, we will have an heterogeneous population of sperm cells in the end of the vagina, close to the cervix, with some sperms that they move quickly, some others that they don't move, with some that they have alteration in morphology and also alteration in the content, the nuclear content of the DNA. After a while, some of them will be able to pass through the cervix and they will reach the oviduct, where they will further develop different transformations that we call capacitation. They will have a reorganization of proteins in the plasma membrane, and they will also suffer a modification in the metabolism that they will end up with an hyperactivation of the motility, to finally reach the oocyte cumulus complex in order to proceed with fertilization. What is more clear is that during that process, what we have is a selection of the sperm population, because the one that we will receive is reduced in number, but also is reduced in heterogeneity. We have sperms with high quality. With the use of with the use of assisted reproduction techniques, we are always with we skip most of those natural processes of selections that we can have, okay? So for that, for sure that you all know that we need to make a selection in the lab, and we'll try also to prepare the sperm for the application of the techniques that we use. We have two main general used techniques. The first one is SwimUp, that is based in the migration of the sperms. Those sperms that they have a high motility, they will be able to escape from the semen sample and pass to the media. And also density gradients technique, where what we use is morphology as the criteria. We will be able to select those sperms that they have a very good morphology without cytoplasmic droplets, for example, that they will reach the bottom of the tube, passing through a dense media thanks to a process of centrifugation. They are generally standard, and in case that you have at some moment adapt which one you decide to use, what we know is that both are comparable. Okay? We have very good studies, large randomized controlled trials, that they show, for example, in the case of outcomes of IVF and ICSI, that there is no difference. And we have a very recent, this was 1 month ago, publication that shows what happens with the outcomes of intrauterine insemination. And again, we don't see any difference. So what we can say is that be calm, you can use whatever fits the follow-up of your lab. Okay? And the main concern that I will introduce here is that probably these techniques are not bad, but maybe are too old. Okay? And just for cultural reference, I want to say that SwimUp was published in 1984, the year that Maradona joined Napoli. And that density gradients was published in 1986, the year that Maradona, being a calciatore of Napoli, scored in the World Cup in Mexico the goal with the hand. Okay? We have other cultural references. I can see more smiles also from those that are not from Napoli. Okay? But I would say probably we can assume that they are maybe too old. The technological change that we have had is really impressive. Okay? So for that, what we have been trying to develop are new or advanced sperm selection techniques. Okay? I have some of them here. Some of them are, for example, related with the integrity of the membrane or the maturity of the membrane, okay? Like zeta potential is not in use at all. PIXI, physiological ICSI or sperm's law, that they are based on the interaction of sperm cells with hyaluronic acid. What we know from them is that they don't show, in large studies, they don't show an improvement in the general population. Okay? Yeah. So probably we cannot consider them a good universal technique for sperm selection. I'm not saying that they are not useful. They can be useful, but for a particular set of patients. Okay? This is a systematic review that probably you all know, where we only see a slight improvement with zeta potential, but it's very low evidence what we have there because we have only one study. We have a very large and very interesting RCT that was the half-select RCT, where we don't see an improvement in the different outcomes of assisted reproduction, except of the reduction in the miscarriage rate. Okay, so probably when we have a recurrent miscarriage, for example, it could be considered as an option because probably it will improve a bit, but not for the rest of the outcomes. Same happened with MAX. I'm not going to explain because you all know what is MAX. Okay, it's based in the depletion of apoptotic cells that they can be in the sample, but even that in that original systematic review, we see a slight improvement in the outcomes. The truth is that in real life and in large studies, we don't see any improvement. Okay? For the general population, again, probably we will have some set of patients that they will be able to improve the results. High oxidative stress, for example, samples, probably they will get an improvement, but not in the general population. MC, for time reasons, I will go straight, because again, nobody is using it, and again, we don't see an improvement. So, this probably can summarize that. This is the publication by ESRE, good practice recommendation on add-ons in reproductive medicine, and none of those advanced sperm selection techniques are recommended for routine in clinical use, with one exception, the case of microfluidics. And what it says is that microfluidics can be considered, Okay, so let's go further with microfluidics and try to analyze quickly, because we don't have that much time, what is the meaning of microfluidics. First of all, we consider a lot of things microfluidics, but the important thing is that microfluidics are based in using navigation mechanisms that control sperm cells in order to select them, okay? And between those navigation mechanisms, we have reoctaxis, for example. That means that sperm cells, they tend to swim against the flow. We have thigmotaxis, sperm cells, they like to be close to the borders, okay? They are roaming through the borders. Thermotaxis, some sperms, they can be attracted to more warm regions, okay, in a range of temperature for sure, that is physiological. And the last one is chemiotaxis. And chemiotaxis means that some substances, they can attract the sperm cells. And particularly this is important because this will happen in the last stage of fertilization in natural conception. They will be attracted to the oocyte cumulus complex. Most of the devices that are available, and the ones that they are commercially available nowadays, they are based only in reoctaxis and thigmotaxis, okay? And the truth is that they show improvement. They show improvement in the outcome, so it's okay. Probably they are okay. This is, again, a very recent publication. This was 1 month ago. It's a systematic review and meta-analysis that has been analyzing all the results that we have to the moment. And what we see is that we have improvement, for example, in mean fertilization rate. We have also improvement in embryo quality. But at the end, we don't see improvement in live birth rate. Okay, that probably is the outcome most important for all of us. So, okay, they are improving the way that we select sperms, but they still are not the good system that we need in the lab. So for that, what I'm going to just try to present other alternatives that we are trying to develop. Just the very last part of the talk. I will talk about a system that is based in chemiotaxis, okay? This was a project developed by Instituto Bernabeu. I'm collaborating with them in the scientific part, and it's called Super Sperm. You see that we are trying to look something really special. It's an O-safe XCDs with a slight modification. We have on it 2 channels, and those 2 microfluidic channels, they have 3 wells. What happens is that when we are doing the decumulation, we preserve the cumulus with the granulosa cells of the same patients, and we are putting in the middle well, well B. As you can see, I hope that you can see it here, it's going to cover the central part of that well. We have 2 channels because at the moment we are using one as a control, okay? But later on, it can be used to select more sperms, if they are needed, with another cumulus. And we put some sperms on well A, the one in the right, and we leave the sperm to pass by the granulosa cells. Some of the sperms, they will get attached to those cells, or they will get not finding the way, and they will be passing time there with the granulosa cell, but some of them they will be able to pass and arrive to well C, the one in the left. And those are the ones that we are going to use in order to make ICSI. The setting perfectly fits the follow-up of the lab, so it's something easy. And at the moment, what we are studying is, in parallel, we are checking for the molecular and cellular property of the sperm that has been selected. And for example, we see that we have a very homogeneous pattern of motility on them. We see impressive reduction in the percentage of fragmented sperm cells with fragmented DNA. We are now also checking for capacitation markers like tyrosine phosphorylation patterns, and we see that even if we do not select through swing-up or density gradients the samples, we put net or fresh samples in the well A, those that they pass through those cells, they are capacitated, okay? And we just finished a prospective randomized control clinical trial in This data is unpublished. We are now waiting for the outcome of the review, okay? But we see, and this was the outcome, was to see embryo quality. And we see an improvement, a significant improvement of embryo quality. We are now in the next step. We are now in the consideration of the ethical committees to start with a new randomized controlled trial with simulated oocytes, and there we will try to see if there is an impact in the cumulative live birth rates. So, yes, a few sentences as a take-home message, okay? Swing-up and discontinuous density gradient are still the most common techniques for sperm selection. And I'm pretty sure, I don't know the results, but I'm pretty sure that will be something that we will see with the survey. The advanced sperm selection techniques available to date show improvement, but only in a particular group or set of patients, okay? We need to consider which technique are we going to use to each patient, fine? We don't have a general technique for all. But microfluidics has the potential to be an universal sperm preparation technique, okay? And what I can say is that further developments on the mechanism used by new microfluidic sperm selection devices are on the way. Thank you very much, and we will discuss it.
Thank you very much to Professor Girela Lopez for giving us such a comprehensive summary of the evidences in less than 15 minutes. Thank you so much. So my pleasure is to introduce the next speaker, which is Dr. Ana Garcia Belda. She is an embryologist at the, let me say, La Paz University Hospital in Madrid. And she's going to talk about oocyte selection and banking. Thank you very much.
Thank you. So thank you for inviting me today. I'm here to talk about oocyte selection and banking. I will start with a brief introduction, then I will explain morphological features and image-based oocyte grading tools, and I will finish with some conclusions. I don't know how, okay. So, for an embryologist, it's very easy to differentiate between a very bad oocyte and very good oocytes in the laboratory. But that doesn't mean that the embryo, the oocyte is competent, sorry. To oocyte to be competent, it needs to undergo both nuclear and cytoplasmic maturation. The nuclear maturation is easy to see in the lab because we are going to see the germinal vesicle breakdown and then the first polar body there, so you have the M2 oocyte in the laboratory. But as well, it needs to undergo the cytoplasmic maturation where the organelles are going to prepare the oocyte to be capable to fertilize. So if it's nearly impossible to see competent or to difference competent oocytes in the laboratory, how could we do if we have a batch of oocytes and we need to select the best ones for treatment, or maybe in an egg donor cycle or freezing, we need to make different batches. So it's very complicated for an embryologist to do that. Then we have the oocyte morphological features traditionally. The COC scoring, cytoplasmic alteration, extracytoplasmic abnormalities, and finally the oocyte size. So a good COC, it's a COC that has an expanded cumulus and a radiating corona. Sometimes we see blood clots traps between the granulosa cells, and it is related to low fertilization rate and blastocyst formation. As removing those clots cannot rescue the corresponding embryo. That's because they come from bad quality follicles. Organelle clustering is the first one because it's very common in the laboratory to find those eggs. The first one is maybe, but the last one is like, oh no. And it's related to low fertilization rates, low blastocyst formation rates, and low implantation. We have back walls. We have two differences between small back walls and very big back walls there. They are related as well to low fertilization rates and blastocyst formation, and that's why we need to take care while injection the sperm. We have to put always the sperm outside those back walls. SER, it's very controversial. It has been postulated that it could be a very good biomarker for future embryo development. And it has been related to low fertilization rates, embryo quality, blastocyst formation, pregnancy, miscarriage, perinatal complications, and birth defects. So it's not surprising that it was recommended at the beginning, I mean, after all those studies, that we should not inject those eggs. But then more data was available, and it was reported that healthy babies were coming from those embryos. And it was time to reconsider the recommendations. So right now, it's like the recommendation is case-by-case evaluation of those eggs. And maybe if you have several embryos coming from those eggs, you are not going to transfer or freeze them in the first place, but we could use them. Cytoplasmic inclusions are controversial results, saying maybe they are related to low fertilization rates, and some of studies say they don't. Zona pellucida abnormalities, they have as well contradictory results. We have different types, the irregular, tubicated, or septated, thin, thick, dark. But I put in this example because sometimes maybe the abnormality is not related to any, I mean, or maybe the studies are controversial, but in this case, in this particular case, zona pellucida was very thin, and embryo started to grow, and all the cells went out from the zona pellucida. So it's just to say that sometimes it's very it's detrimental when it's severe. Perivitelline space, large perivitelline space, is related to fertilization, and we have to take care with the very large polar body, because sometimes in picture A and B we will see that the polar body is fragmented, but it is maybe related to the accumulation, I mean for stripping. But in the very big polar bodies, it could be caused by an abnormal meiotic spindle configuration. So ASEBIR recommendation is not to inject those eggs. And as well, the giant oocyte, it could be a tetraploid origin, so it's as well recommended not to inseminate giant oocytes. And this is a table to summarize everything that I said. There are studies that say maybe it is not related, or maybe yes, and we have to use the oocyte or not. And after all this information, we are still feeling this way. We have new tools based in AI, oocyte grading, that with one picture taken from maybe time-lapse systems or in the ICSI station, if you have any camera there, that tool is going to, I mean, you put all those images coming from the oocytes, and it's going to predict the blastocyst development. There are two types, the egg calculator for freezing cycles, and as well IVF ICSI cycles. So, as I said before, if you have a batch of oocytes and you need to more or less equilibrate them, because you need to do different batches and all of them have to be equilibrated, you have this tool to have the probability to obtain blastocysts. And as well, in IVF cycles, it provides euploidy predictions. So I find it very interesting. I don't have it in my laboratory. I wish I could, but I don't have it right now, maybe in the future.
And take-home message, there are no morphological features of oocytes that have been validated to have a prognostic value. So they are not included in ASEBIR scoring system, in the embryo scoring system. But ASEBIR recommends avoid insemination of large polar body, giant oocytes, and a case-by-case evaluation of SER positive oocytes. And maybe in the future, as more scientific evidence becomes available, maybe they will be included. Right now, we have deep learning standardization of embryo quality assessment, but they require multi-center validation. So thank you for your help and for patience. It was very quick. Thank you very much. Thank you.
No. Thank you, Anna, for this incredible review of all the morphology of the oocytes. I think it's very interesting because we used to inject everything that we have in the lab, but we have to, I think it's important to keep in mind what are the probabilities of each oocyte according to the morphology or all the features that we are watching in the oocyte, exactly.
Yes, because you have all your oocytes there and you are going to, you are not going to throw them to the bin. But we have to take care because we have to keep track of the newborns and
maybe inform our patients about
yes,
the
of course.
Not only numbers, because they keep in mind, I have 14, but maybe 14 really bad oocytes with poor prognosis,
Yeah. So maybe if you have a batch and you have the embryos there, and as I said, with SER positive, for example, you are not going to use them in the first place, but maybe it's the last embryo of that patient and you have to transfer, but you have to let them know that maybe it's going to be some implications there.
Thank you very much. So I think we can go to the last speaker of this session. Thank you, Anna. Next speaker is Dr. Nicolás Prados. He is the head of the lab of Vida Fertility, the labs of Vida Fertility, and now he is a member of the board of ASEBIR, and he will talk about, we were talking about oocyte morphology, and now we will talk about numbers. So.
Okay. Thank you, Irene. Thank you all. It's a great pleasure to be here. So, I'm sorry, we've been seeing nice photographs, video, very interesting information from the lab. I'm going to do a little bit of statistics, a little bit early in the morning to talk about the statistics. I will try to be quick and simple. So, how important is the number of oocytes? Is it a useful indicator? Yes, and we know it from many years ago. This is the traditional Sankara paper, 2011, nearly 500,000 cycles from the HFEA in the UK, and they say that the distribution of the live birth rates, depending on the number of oocytes, is an inverted parabolic curve, where the peak is around, how does it move? Sorry. Here. Here. So the peak is around 15, 20 oocytes. This is the overall. If you distribute it by year, the results are improving, but you get, again, this inverted parabolic curve. If we stratify it by age, we again have the same curve. So something's there. So we have these nomograms, traditional nomograms, where we see that the peak live birth rate is around 15 to 20 oocytes. Of course, depending on the age, results will be lower, but it's exactly the same curve. So there's something there related to the more, the merrier. So, and because you are transferring embryos, you have to do selection. This implies that in this, when you have a small, it's not this one? Yes, no, yes, no. Okay. When you have a low number of oocytes, 1 to 6, the rates are lower. So not only you have less chances maybe there's also a question of oocyte quality there. One must say, in this study, there is only the first fresh transfer. It's not a cumulative life rate. It's not the life birth rate per cycle, per retrieval, only the first transfer. No frozen embryo transfer were included. So maybe they are even higher, the numbers, because if you add the other frozen embryos. Also, this is old data. So maybe we have here single embryo transfer, double embryo transfer, even triple embryo transfer. So maybe the numbers are higher because we are transferring more embryos. Yes, but the general idea is we should get at least 10 oocytes or more. Okay, perfect. So we have solved the question. Number of oocytes is nice, it's good, we should have over 10. Okay, it's a nice indicator, it's perfect. Let's finish the talk here. No, not exactly. So what's happening really? What's happening really is that it is not, it's a useful indicator for us in the lab. We get the patient, retrieval, 10 oocytes, everything is good. But the patient, the clinician, if we are talking with the patients, we want to tell them before they start the treatment, what are their possibilities? What is going to be their live birth rate? Where they are. And this is what I call a post-treatment indicator. We have this number after we start the treatment. Of course, the higher number of oocytes, the higher number of embryos, there will be better quality, higher implantation rates, we'll have live birth. But we have already started. So it's not really a good predictor for the couple. So where is the number of oocytes in all these predictors, if we look at it from this side? So this is a very recent paper, it's a little strange paper, where they get 72 studies with more than 80 models, regression models, different statistics. They look at 132 different predictors, and I have chosen two figures. In this first one, they put which are the most frequent predictors for live birth. And in the age-related group, they say it's female age, FSH, Nanti-Mullerian, endometrial thickness, that's from the article, and the antral follicle count. Of course, the second group, all the infertility-related things, if there's male infertility, the infertility duration, all that. And then there's some IVF-related. How many previous cycles, the hormonal preparation, the stimulation, previous IVF outcomes, did she get pregnant, did she have a live birth, and the embryo grade. Where is the number of oocytes? It would be somewhere down here. So let's say in less than 7 models, the number of oocytes is present. Well, yes and no. I'm going to say right now, another conclusion from the end is that really we have the number of oocytes in all the models. Because as you can see up here, this is a strange, must be near the computer. So you have the anti-Mullerian, you have the antral follicle count, and this is very highly correlated to the number of oocytes you are going to get. So it's in the models. We're going to see it later on. This is another strange figure. Took me 20 minutes to understand it. This is a statistics from a Chinese web page, Site Space. I had to look at it in the material method, what this was about. What they put here is all these papers, and they measure the number of times that different words, different keywords appear in all these papers, and when do they appear. So they make like a scatter plot of when things appear. This is like saying when people started to study something and the impact, and if it's being continued studying. So you can see 3 different colors, like it's very difficult to see, very light green, a very thick green, that's the top, or a middle green. And you can see at different time, different things were included in the different models. And here, the number of oocytes appear by the end with a peak starting 2018, with a peak in 2021, something quite new that people are starting to look at right now. So something that was not included, it's been included now. So, is it good again? What can we say right now? What's the state of the number of oocytes as a predictor? And I'm going to show you 2 papers. Okay, one is from Both of them are quite recent. We have this one from La Marca, 2021, where they, again, we collaborated with Sunkara with a big data from the UK, from the HFEA. They start doing models, and the model is including the age, infertility, time before the first cycle, the cause of infertility, and they make a nice predictive model. If they add the number of oocytes, the model has a higher overall prediction, a better quality. I'm not looking at the numbers right now. And if I add the number of embryos that I get, the model is even better, of course. But these are post-treatment indicators, but we can see here that they are strong indicators of live birth. Then we have this model, which is a different way of using the number of oocytes. What here McLennan did with his colleagues, they have another big data, nearly 100,000 cycles. They make their model, and in their model they have the cycle number, if it's first, second, or third, the woman's age, if they have a baby or not, the kind of infertility, the body mass index, and they make their nice model. If they have the anti-Mullerian, that's the second model, they have only 53,000 cases. It's better, it's a better model to include the AMH. If they add it, then they take out the first cycle, and they're using the model for the second, third cycles. The number of oocytes they have from the first one, the model is even better. So what they're saying is, once a patient has a nice response, we get 10 oocytes or more, that means in following cycles that the possibility of a live birth is higher than with a lower one, okay? That's logic. We know that low responders exist. We know that a low responder, again, will probably give another low responding cycle. But, okay, they prove it in this way, with the numbers way. I must say in the previous one, that one of the conclusions here, both number of oocytes, number of embryos are post-treatment indicators, but they say, what I said at the beginning previously, that the way to add number of oocytes in your model is using anti-Mullerian or antral follicle count. If you introduce them, you are having a more robust model, which is what they did in the McLennan thing. So, just to finish, so this is more or less the picture of how we can use the number of oocytes to predict live birth. What else can we use the number of oocytes for? Okay, we know that the more the better, good prognosis, we are in our lab, we have 15 oocytes, hooray, everything's going to be nice. What else can we do? I'm going to show you some numbers of what we are doing in our group. I'm tutoring a PhD thesis where we are looking at nearly 40,000 cycles from 3 centers. We have 48 variables. We want to construct our models. We are using number of oocytes as a dependent value. We want to know what is predicting the number of oocytes in this case. But we are focusing in explaining or looking for factors that explain the empty follicle syndrome, when you don't get any oocyte, or what can we call a low yield recovery. When can we say that something is off? If I'm expecting 10 oocytes, when can I say that I have a low yield? When I have 3, when I have 5, when I have 7? So when they say, oh, we are missing 3 oocytes, is it chance or is it a real problem? So we are starting, we see that the best prognosis is very obvious of the number of oocytes is the number of follicles over 12 the last day of the ultrasound, so it's perfect. 10 follicles, I'm expecting 10 oocytes. But when we see the distribution, you can get more, you can get less. So we have to put a threshold, a cut point of what we called a low yield. And we see that it's not obvious. We have made 4 groups. we have used this formula to compare, looking at the spectrum from the number of follicles, if it's under 1 sigma, 1.25 sigmas, up to 2 sigmas. Depending where we put the cut point, if we are more restrictive or less, from all these 35,000 cycles, we have more or less cycles that we can say that it has a low yield. So in the most restrictive one, only 2% are low yield cycles, including empty follicle syndrome, no oocytes. And these are the first things that I can tell you. We are polishing the models. I hope that sometime I can give you the exact numbers, P's, and all that. But what we are seeing is that we have a mixture of factors in less restrictive models. If we go to a very restrictive model, we only find estradiol on the triggering day. Logical, if I have 10 follicles, but very, very low estradiol, something is happening. You may recover less oocytes. Because some data is old, we have the type of triggering, which ACG, we have less low yields than using antagonist. Okay, maybe the antagonist is an indirect triggering, so maybe there's a higher risk of happening funny things. We have the body mass index, very logical. In very obese women, we may see in the ultrasound 10 follicles, but it's more difficult to get to the ovaries, so we may recover much less oocytes. And the progesterone on the triggering day, of course, if the woman has ovulated, we are going to recover less oocytes. In the other models, there are more factors. I think that these are the things that gives high variability, the number of oocytes we get in the lab. Okay? And there are many more things. And I like to point out the year. So some years you have better recoveries than other years. The clinic, some clinics has a trend to have lower yields than others. And it's not here, we feel that's going to be an important one, but it's a much more complicated model because there are very many different categories. The clinician, we know that there are clinicians that recover less oocytes. I can say it, I cannot give right now, I cannot put even this here, but we know that there is something there. We only have to polish our models. So, this is I wanted to talk about you. Is it a good general predictor for the patient? No, because it is post-treatment, but it's good for us. Once you know that a patient has a good response, you know that that couple has a good prognosis, and you can use anti-Mullerian, you can use antra-follicle count in your models to predict the number of oocytes, the better, the more the better. And also with the number of oocytes and the expected number, we can start looking at a little more objectively this concept of what is a low yield number of oocytes. And I stop here. Thank you very much.
Thank you very much for this excellent talk. A lot of information. I think there's room for discussion maybe later on. Thank you. So now I have to introduce Irene Cuevas. She's going to give us the first results of the survey that was presented in the introduction this morning. Thank you so much.
Thank you, Alice. Okay, as all you know, we prepared, together with all the scientific committee of this meeting, we prepared a survey that was distributed by all the members of all 4 societies that are conforming this amazing meeting. So I'm going to present the results that correspond to our part of the meeting, to ASEBIR, the gamete retrieval and selection. And why this survey is important for this meeting. I think the importance is to capture the current practices from embryologists from our 4 societies and trying to identify strategies that could help us improve our workflow and results by means of common consensus or guidelines. So this is what we found after the recovery of all the surveys. We had I think it's a very good number, 173 responders to the survey. And the respondents, because we had people from other European societies that responded to the survey too, but the mainly countries were Portugal, Spain, Italy, and Greece. Of course, they're represented here in this meeting. And we recovered too some data regarding the demographics of the people who were responding to the survey. The gender, the clinic type, we know there are differences between public and private institutions, the experience levels, etc. And we made an analysis putting all those data together. So to start with the survey, the results of the survey, we will start with the sperm selection. And first question was about which sperm preparation method do you use for non-severe sperm samples? So overall, for the general population in Europe, for all four societies, the most used techniques to prepare the semen samples are density gradients or swim up, but microfluidics or other types of sperm selection, new ones, are starting to increase along the societies. But it's interesting, it was very interesting to me that when we do a segregation between the country of origin of the respondent, I don't know why in Greece there is no swim up. I don't know if it's something general from the country or maybe the respondents are not using this kind of technique. But in Greece, there was no swim up that is very popular in the other countries. And another thing that was very interesting to me, and we can find differences between countries, is that in Spain and in Greece, we are increasing the amount of use of these new techniques like microfluidics or masks to select the sperms. And it's less popular, or even, I don't know, maybe less valuable, the use of this kind of technology in Portugal and in Italy. So I think this is something that we have to discuss later in the discussion. And I wanted to see if there were differences among private and public institutions, because all we know, I work in a public institution, and we don't have the same possibilities of using all the things that we have in the market inside the public institutions, because it's really hard to get some things because are costly or whatever. So we found in the survey important differences with this aspect. So microfluidics are only used in private institutions. None of the public respondents are using this kind of techniques to select the sperm. So I think it's very, very, very interesting. And if we do the segregation between all the countries that were participating, it's the same situation. Only in private institutions, the use of microfluidics is increasing. We were asking too, another question of the survey was, what is for you the main advantage of using microfluidics inside the laboratory? And it's curious that the Italians are really skeptic about the use of microfluidics. I don't know if there is no spread of this technique, or maybe you have been using this technique for so long and you know now that microfluidics don't work. So I think we have to discuss with Italians why you don't like the microfluidics. And for the rest of the countries, the situation is very similar. So we can find, again, differences between private and public institutions regarding what is the advantage of using microfluidics. And in private institutions, they find that the main advantage of using microfluidics is the improvement in the DNA fragmentation of the sperms. So I wanted to make a small discussion about the results of the part of the sperm survey. So I wonder if public institution do this technique? So I can respond about a technique if I have never used it. So if in public institutions there is no possibility of using microfluidic, how can I answer this question? So it's important. And even in public institutions, in my hospital, for example, we don't have even the possibility of testing DNA fragmentation in the sperm. So if I can't test, there is no possibility of having an opinion on this topic. So how many people in this forum is working in a public institution? How many of you are using MAX, microfluidics? No, not fast. And how many people work in private institutions? And how many of you are using MAX, microfluidics for all your patients? And if the cost for the patients was zero, would you implement those MAX or microfluidics for all your patients? Of course, I think that everyone, even public institutions, will do the introduction if it was cost zero. So the final discussion is, as scientists, do we trust in this kind of technology? I think yes, and more after the presentation of Dr. Girela. I think it's very interesting, and all we would like to introduce in the lab, but has some money increase of the treatment, so probably there will be a slow implementation because of the cost. And let's go to the part of oocytes. Anna has introduced the oocytes with reticulum into her presentation, and I think it's a very, very interesting topic because for several years, some societies, like Alpha, for example, recommended not even to inject or take into consideration that kind of oocytes. So those oocytes were discarded since the very beginning, but through the years, as Anna said, some societies like ASEBIR included those oocytes into the classification systems, and now Alpha recommends that you can consider those oocytes for your patients. So the majority of the respondents of the survey said that we're injecting these oocytes, but we found differences among the countries, the different countries, and it's important to say that in Italy and Greece, the majority of or there is a big amount of respondents that discard directly the oocytes with reticulum. It's probably because they have more influence of Alpha, the society that recommended at the very beginning to discard those oocytes. And for example, in Italy and Portugal, they use that kind of oocytes for research purposes. That is not an option for Greece or Spain. I think we are more using this kind of oocytes, but we can see differences, and I think it's because of the societies that are giving you the recommendations of what to do with specific populations of oocytes. So the discussion is here. Will be there different responses in the future after that acceptance of Alpha to use those oocytes in our patients? And now that it's considered, you can consider those oocytes to inject and into the pool of oocytes that you have for your patients. How many of those oocytes could have been produced a baby? So maybe we have been discarding oocytes that could have been a baby in the future or in the past. And apart from aneuploidies, I think that we were discarding those oocytes because it was related to the possibility of increasing the risk of aneuploidies, perinatal malformations, etc. But maybe there are other things like epigenetics or something like that, but if we are not ready to test epigenetic changes in our oocytes, how are we introducing all this pool of oocytes into the pool of oocytes for our patients without testing? Why the situation is now a different situation? And why the oocytes that had reticulum were so bad in the population of oocytes? Because Anna presented a lot of other dysmorphisms that are related to low fertilization rates, to low blastocyst rates, and were not so bad in the cohort. Why? Why only those oocytes? Because of immature of the cytoplasm or lower competence of those oocytes? The thing is, now we can use them, so let's see what are the results. And going to the last part of the block of ASEBIR, we will talk about numbers. So how many oocytes do you think is a good number for warming in the oocyte donation program for a standard donation cycle? A cycle where your goal is to transfer one single blastocyst without an euploidy test. So in the general survey, we can find that 6 to 8 is the most popular. We feel comfortable when we have those numbers, but the reality is that we can differentiate two types of responses to the survey, because we have two types of societies here. We have Greece and we have Spain that we act as oocyte providers for Europe. So for us, I think that we think more, what do I have to provide to increase the probabilities of my consumers to get the patients pregnant and everything. So the most popular, again, is 6 to 8. And it was really interesting to me, reviewing the results, that in Greece, 8 to 10 is not an option. So when I first saw the results, I thought, yeah, now I understand why Greece is presenting the results about vitrification. Probably in Greece, they have better vitrification programs that allow them to use less oocytes than in other societies, because they do better. I don't know, we will see during the discussion. And for the other two societies, Italy and Portugal, that they are like more oocyte consumers. Of course, they vitrify oocytes too, but they are more consumers. We can see that in Italy, 6 to 8 is a very good option, but in Portugal, they want 2 more, please, 2 more oocytes to increase the probabilities. And I was looking at the results. It was interesting to me. What about the experience of the embryologists? Because maybe if you have less experience, you want more oocytes to have more chances to have a baby. It was really, really, really interesting to me to see the results in this aspect, because younger embryologists need or are asking for less oocytes. So it's interesting because the more experience you have, the more comfortable you feel with less oocytes. So this point is really interesting. So thinking about what could happen with this, I thought that maybe young embryologists arrived here with those numbers. So the banks are providing 6 to 8. They feel comfortable because they have started to work with those numbers. And maybe, sorry, it's ready. Oh my God. I will take Anna's time, 5 minutes, 5 more minutes. So maybe all the embryologists, we suffered the transition to vitrification program. We started to test everything, and maybe we have that in mind. Probably with the use of the fast vitrification protocols and everything, we can maybe improve the results and lower those numbers for the vitrification program. And to finalize, what kind of oocytes do you freeze in your lab for the oocyte donation program? we had three different options, all metaphase 2, only morphologically normal oocytes, to freeze everything, mature and immature oocytes, and of course the possibility we don't have a donation program. It was very interesting that none of the participants of the survey choose the option of vitrifying mature and immature oocytes. So I think this paper is, is very interesting that the in vitro maturation of oocytes is still challenging, and we are not using it for real patients or for the donation program. And according to the differences among countries, of course, in Italy is very popular the option of no donation program. In Spain, we tend to vitrify only metaphase 2, and in Portugal, they take more into consideration the option of morphologically normal oocytes. And according to how busy the embryologists, how many embryologists we have inside the lab to work with those oocytes, there were no differences according to this topic. The experience of embryologists was giving differences again, because the younger embryologists don't freeze only or don't take into consideration the morphology of the oocytes to freeze them or not. So only experienced embryologists keep this in mind to freeze the oocytes. So I think that maybe the experienced embryologists have acquired this natural intelligence that help us in selecting the best oocytes to freeze. And nowadays, as Anna mentioned in her presentation, we have tools based on AI that could help us in this selection. So to finalize, I think that in general, there was largely across demographic consensus among the respondents for most of the questions, with certain differences that would be interesting to follow up and understand. And some of the differences that we found in the survey can be explained by availability of or accessibility of certain techniques in the laboratory, sociocultural differences among countries, or the start of change of the role of embryologists with the use of new technologies. And thank you very much, and sorry for the delay.
Thank you very much for these really interesting results, and thank you for those participating in the survey. I think we have to invite to the podium the speakers in order to start with the discussion.
Shall we stay here or the?
Yes, I think so. Microphones for there. Yes. Yes. First of all, there is any question in the floor for the speakers? Any comment? Yes?
Yeah, we have one microphone in the room here.
Hello, my name is Yannis Fontouris from Greece. Congratulations on the presentations. They were really interesting and really very relevant to what we do every day in the lab. I have one particular question for the innovative safe micro device that you have made. It is very interesting. The concept is very clever and very simple based on the biology. I would like to ask, did you test the spermatozoa from well B, the ones that stay in well B and attach on the cumulus cells? Because it could be that these might be even more physiological than the ones that cross well B, do not bind on the cumulus cells and end up in well C. Did you test in terms of capacitation, fragmentation, and
yes, but we have some technical problem to test them, because of the presence of granulosa cells there. Okay, so this is not making it easy. What I would say is that this is the concept of being trapped in hyaluronic acid sperm, but I would say that physiologically this is not the reality. Because the reality is that those sperm that are able to fertilize are those that are able to pass through the granulosa cells. They are not attached to them. They stay with them. Probably they will suffer some modification, but after that they will have to pass the zona pellucida and they will have to make the fertilization, the fusion of membranes. So, we assume something that probably is not completely true. So I would say it's not because of the attraction, but because of the interaction. Is the point that we have as an hypothesis. But we know that the best ones, for what we have been able to test, because I was telling you that from this technical problem, sometimes we are not able to perfectly recognize the nucleus of the sperm cells, comparing to granulosa cells that we can have there. The best ones are those that are able to arrive to well see.
Thanks.
There's a question here. Maybe you can move to the microphone just behind you.
Hi, thank you for your presentation. This is Josu from Spain. I have like two different comments to the speakers. The first comment is about the microfluids and specifically with the results from the survey. I think we have a little confusion with the microfluids. I believe a lot in the microfluids, but the problem in the papers, not all are microfluids, and we have the concept in the wrong way, because now in the field of the providers, you have in the merchandising two different systems, and one is no microfluids, and the people in the lab or around the world, they are using like microfluids, and the problem when you are using this like in the regular technique, now you have an add-on. This is the problem. And one of the things the papers is telling you that reduce the DNA fragmentation, and of course reduce because you don't centrifugate, and if you don't centrifugate the sample, then the fragmentation is going to be less. Do you have any comment about this? And another is for Anna. I don't know if you read specifically with the oocytes with the REL. The problem for me, we have now a new consensus about alpha, but for me it's a little strange because the last paper telling us using this kind of oocytes increase the neonatal abnormalities more than three times, and we have to be concerned with this. I don't think we have to personalize something when we are using one oocyte and we are going to increase something wrong in the neonatal babies. We have to think about it. This is my comment.
Okay, we'll start with the microfluidic part. I completely agree with you, Josu. We have some devices that they are sold as microfluidics, that they are not really microfluidics. But the main problem is what is microfluidics. I would say this is like with yogurt. If you don't have live bacteria, you cannot call it in the market yogurt. Okay, yeah. Maybe we need to regulate a bit more this, or we can do another thing. Don't use the word microfluidic, but use the mechanism of sperm selection that you are using there. Okay, and then it doesn't depend on the volume; it depends on what are you using to select the sperm cells. Okay, so maybe this is the idea. The second one was sorry
For Anna, for the circ oocytes.
Yes, so as I said, I mean, it's very concerning the use of these eggs. The thing is that it's happening, but there are also as well healthy babies coming from those eggs. So if you have a patient, that's why the case-by-case evaluation, because maybe you have a patient that only has one oocyte and it has SER. I mean, you are going to use it, you could acknowledge the patient and then keep tracking that baby that is coming from that SER positive eggs. And then we will have information, because if we haven't used them in so many times, or maybe nobody annotated that it was a SER positive oocyte, and babies were coming, but nobody knew that they were coming from those oocytes. It's like knowing nothing. I mean, you are, as Irene said, there are a lot of clinics and centers that they are using those eggs, but they are not maybe telling anyone the results.
And same with other dysmorphisms with
Yes,
the
I mean,
oocytes.
it's
So maybe
important.
we don't know, probably other dysmorphisms are giving us more probabilities of having abnormalities in the embryos, but if we don't do the annotations
Or maybe the
with
mixture, or having more than one feature, because sometimes you have SER, back wall, irregular zona pellucida. The important thing here is that we have to annotate all these features and keep track of them, so we will have more information, more data, and we will be able to decide better if we should be using them or not.
Mr. President.
Mr. President.
Thank you so much again to all the speakers and also to ASEBIR. It wouldn't be impossible to discuss everything about the topic of the gamete selection and in particular for sperm preparation. I have a question for Jose. We didn't have the possibility to discuss about the temperature for the sperm preparation. Have you had any experience in a lower temperature than 37 for sperm preparation? What do you think about?
Yep, I have that experience. Thank Valerio. I have that experience, but it's close to a very sad situation. We're working on thermotaxis, and I was collaborating with Serafín Pérez Cerezales, that he was a guy that was he did his PhD in Weizmann Institute in Israel, where I was discovered the process of thermotaxis. Then he moved to Madrid, and we're collaborating because we're checking for the role of rhodopsin receptors that are present on sperm cells, and we were trying to characterize the localization and their function on that. Sadly, he passed away during COVID, okay, so that project was closed, and for the moment we have not the idea to continue with that. But just like a few weeks ago, we have a very interesting paper, you haven't read it, related to cat sperm. I don't know if you have read that, but cat sperm seems to be a thermotaxis receptor for sperm cells. And it can be modified, its activation, because of the temperature. Okay? There are some devices that would be probably available in like 2-3 years that they will be connected with that. And this is also a very good mechanism of selection of the sperm cells, because we know that during the oviduct transit, they will follow that temperature gradient. And also with the implication of the activation of cat sperm, etc., would be interesting.
Stefano?
I have a question for Nicolas, because I was interested about the number of oocyte to worm in oocyte donation cycles. As from the survey, we saw that from 6 to 8 seems to be a good number. But do we have similar models to understand which is the optimal number to worm in oocyte donation cycles based on the clinical characteristics of the recipient?
In my experience, well, first, what I talk about the number of oocytes, it applies also to donors. The best donors have a good retrieval from donors when you get 15 to 20 oocytes. The more, the better. You share it between different recipients, but when you get a donor with only 6, only 8 oocytes, that would probably be a poor donation. So it applies also to donors. The number, in my experience, it's a balance. Because if they survive, if they are fertilized, usually with only 4 oocytes is enough. So I would say, okay, we should give only 4, only 5. The problem is the risk that you have a poor warming, the risk you have a poor fertilization rate. So there are variables that you have agreed, you have a dispersal of values. So you go upwards in order to really be sure that you have one, so depending on the problem, 2 blastocysts. And that's why we move to 6 to 8. But when you go over 6, you will be increasing the number of frozen embryos in your tanks. So we cannot give a number in order to get one good blastocyst. That's the problem.
Yeah, can I add something? I think that that is very interesting, that when we have the patients in front of us, or maybe one of the, in other words, maybe all the predictors that are being developed and that are developing right now, maybe they should include what are the future perspective of the patients, if they want, if their family building will be 1, 2, or 3 children, because the amount of oocytes that we will need for that specific couple will be absolutely different than one couple that wants only 1 child. So maybe the predictors to be really helpful for the management of the cycle would have include that reproductive, I don't know, expectation or something like that.
Yes, for sure.
Because it is completely different, completely different. Any other question, comment?
I will ask a question to Dr. Prados, because this was a question that one patient took me. She was a statistician, a very young patient, and she said me, I will not have a 50% baby. I will have a baby or not. So what's the probability of having a baby? And I said, it's a matter of chance. It's a matter of the number of oocytes you will have. And she said, okay, I will have 50% with 10 oocytes, maybe. And she said, I have not 5% for every oocyte. I will have 50% to have the right oocyte. So why don't you catch that oocyte instead of giving to me a standard stimulation and having hyperstimulation or what else? So from a statistical point of view, I would interesting to have your opinion.
I think that there's been a trend, it was a very strong trend of mild stimulation, even single follicle retrievals. My feeling is, there are not many studies, but my feeling about this is that we are not as fertile as other mammals. We don't get pregnant after each intercourse. So if we go one by one, we are not getting always the best oocyte possible. So we are getting an oocyte in a mixture. So that goes to the idea that I need more oocytes, so I have some variability, and in that variability, I will get the really good embryo. We know that with age, there are women over 40, more than 50% of the oocytes are going to be aneuploid. So it's not that we can go with a single stimulation to get the perfect embryo. I think that we, as humans, we need more than one oocyte to improve the chances of each treatment.
That's a good point. Professor Talebi.
So I think the right answer why we are using Swim-Up and Percol Gradient until Maradona time is because we still doesn't understand the real characteristic of fertilization of sperm. So that is my point. If we still don't understand which are the characteristics of the fertilizing sperm, in which way we can choose right methods to select. For example, normal swimming sperm are not able to pass the uterojunctional function. So, because they lost some molecules on the surface of the sperm. But at this point, we are able to select sperm just for motility or morphology. So all the methods as just palliative. I appreciate your system because it's based on chemical attraction. But at the same time, you are losing the other characteristic like thermotaxis and rheotaxis. So maybe a combined system should work much better.
Thank you, Professor Talebi. I completely agree with you that we still don't know which sperm is the right sperm to fertilize an egg. Okay, and for sure that with this approach, like the others, we are losing characteristics that maybe they will be right to select better sperm on them. But what we want to introduce is a universal or a general technique that gives you almost the best available sperm that we can have in vitro. Because it's true that if we try to understand the complexity of the fertilization, natural fertilization process, okay, we still don't know. We have a lot of clues that we don't know, which not even the translocation of proteins that we suffer, the modification in the fluidity of the membrane of the sperm cells. We need to continue working on that, and I'm a cell biologist, and I work at the university, and I'm close to the clinic, but I'm doing basic research on that. But what we try is to give another option, a general system for sperm selection, because we are focusing, for example, in DNA fragmentation. But who analyzed DNA fragmentation of the sperm samples that have been selected by SwimUp or density gradient? Probably nobody. Okay, yeah. And we have results that they are, I would say, okay. But we have been improving how we test embryos. Now we have computers that they are checking for the morphological features of the development of embryos. We test it genetically, so we have euploid embryos, but we still are able to pass that rate of good results in the clinic. So maybe trying to give another option, avoiding for sure centrifugation, try to make it more natural selection, we can try to improve that. We will see, the numbers will say what we have. Thank you.
Okay, now I think it's time to wrap up this session. Thank you for everyone to be here in this session, and thank you to the speakers for those amazing presentations. We can go on with the discussion during the coffee break outside, so let's go.